are from abroad. They are not from Oman. In fact, transplantations performed in Oman are only 256 till the end of 2013. In fact, in 2013 there were only 8. And this makes only 15.5% of the total of transplants. And this brings the figure down from 40.2 to 6 per million per year only. And also, this is a problem that we have to look into it, is that after 1998, 54 living-related transplants were performed abroad. People go with their brother, with their mother, and they go abroad. We have to look into the reason why they don't have confidence in us. And here is the same source that Professor Farouche has shown. It's the Organ Procurement and Transplantation and Scientific Registry of Transplantation. These are American organizations, but they take the figures from the WHO. And here we can see that the rate per million per population is not that great in Oman. Although in 2009 we performed the highest number of transplants. Living-related transplants, it was 23, and after that it came down. Another area of improvement is that we have to deter our patients from going abroad and get a transplant. Usually they pay for it. And here, if we see the dynamics of transplantations, from 88 it was mainly India. People were going to India. Then in 1995 there was a ban on commercial transplants in India. So then Iraq, people were going to Iraq with very dreadful complications. And Dr. Qasim, of course, we have seen together all these miseries. And after that to Pakistan, which are but not much better than Iraq. China has been only for a few patients with technically good results relatively, but of course these kidneys are from executed prisoners, which evokes a very serious ethical problem. In April 2008, I think Professor Nasser Farouche and myself, we were in the panel of the Istanbul Declaration. And the Istanbul Declaration of Istanbul, it was a framework for the ethics of transplantation worldwide. It has emphasized one thing, that we have to fight commercial transplants worldwide. And one of the ways to combat commercial transplants are, one is by forbidding these people to go abroad, but also, and most importantly, it's by assuring self-sufficiency in the country for transplantation. If we don't have self-sufficiency in our country, then the patients will be forced to go abroad to get any transplant anywhere else. So it is both things that should go together, having self-sufficiency in our country and also to have legislations that deter patients from going abroad. And the Declaration of Istanbul was in 2008. And here we did the transplantations in Oman, in commercial transplants. And we see that in 2008, after the transplants, there was a decrease, but was not significant. That's possibly there was a question of time, but there was significant improvement immediately the year after the Declaration of Istanbul. In fact, the number of living-related transplants in Oman increased, and at the same time, there was decrease of the commercial transplants from 49 to 34, and the proportion test, the chi-square proportion test, was significant at that time. Unfortunately, this improvement was short-lived, and again, the number of transplants came down, and these are the combined transplants of both Royal Hospital and Sultan Qابوس University. And again, there is a surge in commercial transplants for our patients, and here we see the inverse relationship between commercial transplants and the living-related programs in Oman. Another area of improvement is that it's, of course, and I think we agree all, is that it's a necessity that we reactivate the deceased donor program. The success was not much sustained. Also, it was very satisfactory at the beginning. We performed 10 transplants from 98 to 98, and then again, after more than 1 decade, 2 were performed at the university here. Unfortunately, all the donors were foreigners. So there were no Omani donors for the deceased donors. And I think we have to work for this factor. And Dr. Sam Farouche has shown this area, and we are very honored. And the Iranians were first commended for the number of transplants that were performed, although not people were agreeing with them. It was a necessity, and I think they performed great results by the program. But also the recently flourishing deceased donor program is internationally recognized. And in fact, in transplantation, the Journal of the International Society of Transplantation has commended the development of this organ donation and transplantation in Iran, and that was published just a few months ago. Another area of improvement is that till now we are performing open surgery for nephrectomy, and I think, as Dr. Farouche has mentioned, and it is mentioned now in literature, is that laparoscopic living donor nephrectomy is the standard of care in the state-of-the-art hospitals. But I said that we are optimistic because we have assets that we have to use, that we have to activate. So what are our assets? We have motivated, multidisciplinary team. Urologists, vascular surgeons, general surgery, nephrologists, nursing, pharmacists, social workers, all the ingredients of a successful program are there. The members of transplantation are competent, skillful, and not only they are skillful, but they are also willing to improve and to learn the new technique, which is very important for any successful program. Our administration is open-minded and supportive for the development of the program. Of the assets also, in many countries there's problem of medication. Medication is available at the university and not available and accessible to all the visitors. The labs are effective, and now we have acquired the HLA typing and detection of antibodies by solid phase assay, by Luminex, by single beads. And for example, we had it since a few months, and already of the 5 patients in whom we have looked into the antibodies, 3 had donor-specific antibodies. So I think this will help a lot in pre-transplant workup and also in the post-transplant follow-up. And we have also our supportive services, the pharmacists, the labs, they have very active follow-up of the patients, and it's common that we get a call from the lab that this patient has a potassium of 6, or this patient has a potassium of 3, or hypocalcemia, or that the dose needs to be adjusted in such and such patients, which is very important and which is an asset for a successful program. Another asset is that our public is potentially responsive to transplantation. Often, sometimes we hear that, we have some resistance. People here will say no, will not agree. But in fact, we have done this study on more than 300 subjects. And in fact, they say that 38% of the persons who answered the questionnaire, they had a family member with a kidney disease or received a transplant. 60% of them would donate to a relative if needed, but 49% of them knew that donation after death is permitted in Islam. So here it is our deficiency. And 37% of them would donate a kidney or organ after death. In fact, this rate came to 52% in patients, in subjects with postgraduate qualification. And we presented this at the 9th Congress of the French Society of Transplantation, and it was published in Transplantation Proceedings our population. So I think our population is potentially permissive for transplantation, but we have to work for them. Another important asset is that we have a legal support, and His Eminence, the Mufti of the Sultanate, has given his approval for the deceased donor to consider brain death as a legal death, and for transplantations and to perform organ procurement and transplantation from deceased donors. We had a Ministerial Qarar in 1993 that I mentioned, and also now there is an international framework for transplantation. For example, living unrelated, altruistic living unrelated are permitted, etc. So what we think to be the practical approach, one is to have a multidisciplinary approach, all the teams that I mentioned. That's good so that you can see it twice, okay. So, and we thought we have a multidisciplinary approach, proper logistics in terms of organization, and to have the protocols, guidelines, and pathways so that there is homogenization of the transplantation. Also, we should have the state-of-the-art technique, which should be to our university. Cooperation is important in every field, and especially in transplantation, regional and international, and we are honored to have our distinguished team here and we hope for a fruitful cooperation, and of course conferences and updates to know what's new and how to apply better the new technique. So what is the perspective of our cooperation? So we thought that we may benefit from your technical expertise in terms of surgical training, in terms of donor laparoscopy, etc. Expert exchange. We always have many things to learn from each other. The nursing is a major part in surgery, and especially in transplantation, and we are aware of the quality of your nurses, so I think we may benefit from training our nurses and also to have an exchange of nurses. Teleconferencing, which is a very practical and cost-effective mean for technology transfer. And also, the Iranians, we learned that they have a very unique model in transplant coordination, where a religious figure will go to talk to the people, which will solve immediately the religious aspect. Of course, this is besides the other technical aspect of the transplant coordination. So we look forward fruitful cooperation, and we welcome you again. Thank you very much.
Thank you very much, Dr. Nabil. Any questions from the audience? Yes, Dr. Sanfroush.
Thank you very much for all those efforts during these years, good quality work. Transplantation surgery is a social kind of problem. It's not only a disease like kidney stone or other things, but it's really a multi-specialty and a teamwork. It's really difficult, as you mentioned. We have had the same problems in Iran. But sometimes some people are very hardworking and smart. In our country, a few people worked hard for this coordination teams. They are really the cornerstone, the main issue in kidney transplantation. Dr. Najafizadeh in our university, she worked very hard. She went to Spain, she worked hard, and she put all her efforts to establish good procurement. And in Iran, our university became #1 in harvesting the highest number of harvesting in, but there were other teams too of coordination. But she did a good job. She's working scientifically, and I think it's very good to have a good collaboration, and we can exchange ideas because we have similar cultures in our countries, and I think our experiences also, inshallah, could work here to develop the cadaver transplantation programs. And until we bring to about 50% of our transplantation to cadaver, we cannot say we are successful. But I am sure with the determination and with the good, excellent experience that you have, in very near future, we will have very good improvement in our brother country, Oman. And we in Iran, as you mentioned, we have 70 million population, and we have many colleagues, many programs, and we are all very eager to have very good collaboration. There's a lot of things we can learn from you, as we have done in the past, and also we can exchange ideas and to improve the transplantation in our area. We are open for fellowships. We have 1 year transplant fellowship program. It's 1 year, and I personally have very good experience in this regard. We have trained about 30 kidney transplant surgeons. They are doing transplant in the country. If you have Omani surgeons, many of them, you should have many transplant surgeons, because one person gets tired of doing complicated cases. If there's one center, all complications, difficult cases will come to them, so after a while they will get tired and they won't have. So I think you need at least a couple of surgeons, 5, 6 of them, to work together, and transplantation issue needs some leading person to devote their life and time for this very difficult issue. And thank you very much for your experience.
Thank you. Thank you
Thanks,
very much,
Mr.
Professor Nasser. Thank you.
Okay, so thank you very much, Dr. Nabil. We'll go for the next talk. And is Mr. Abdullah Battashi here?
No.
Yes. So Mr. Abdullah Battashi from the Ministry of Health, we are honored to have you here with us, and he's going to give us a talk about the Health Vision 2050.
السلام عليكم ورحمة الله وبركاته. First, I'd like to thank the organizers for providing me this opportunity to talk a little bit about Health Vision 2050, particularly which relates to health professions education. It's maybe a little bit unlike the previous presentations. But I'm here just to provide some glimpses of the health vision, particularly for academia. The Health Vision 2050 initiative began a few years ago, particularly in 2010, with an international conference where both local experts as well as international experts were invited to discuss the future of health for Oman. And the health vision, there's a main document which is the Health Vision 2050. From the Health Vision 2050, there are 24 strategic studies. One of these strategic studies is health professions education. I'm just going to provide a process of how this big document was done, and maybe give some numbers regarding the institutions and enrollments, some proposed strategies, and frameworks and career pathways. Now, with regards to health professions education health vision document, it started by looking at the current situation, where a pistol and SWOT analysis were done, looked at the literature review, international reports, documentations, WHO reports, Lancet. It looked at, again, both national and international expertise. And the health professions education document specifically, many people were involved in this document, from Ministry of Health, from Sultan Qابوس University, even from private institutions, other such as the private universities that were here. So a lot of people were involved. Over maybe 150 to 200 people were involved in constructing this document. Looked at the challenges that we are facing in Oman with regards to health professions education. We looked at the international trends to see what is happening out there so we could learn from these experiences. Then guiding principles were formulated, career pathways were done, projections were made, criteria for health professions education, and then visions and actions. This is a generally, I'm just going to highlight on some aspects all of this process. Of course, this is just to show that Oman's population is growing, increasing. The health facilities in Oman, a total of 65 hospitals with almost 6,000 beds. And these are some indicators. As of 2012, 19.5 per 10,000 of the population for doctors, 43 for nurses, and so on. The higher education institution, the students, well, in 2010, 2011, around 17,000 were enrolled. Now this number has increased a little bit in the past couple of years. Local institutes, 55 institutes. Now, this is one of the challenges that we are facing, is that a lot of the high school students, when the post-high school, they actually go to engineering, business, and information technology. Almost 2/3 opt to choose these specialties, and only 5.5% go to medicine and health. That is a challenge. Actually, this is 2012 statistics. In 2013, that percentage went down a little bit to 5.2, unfortunately. Again, looking at approximately 6,000 who are enrolled in medicine and health related. And of course, the Ministry of Health has multiple institutes, the nursing, allied health, pharmacy, and the total enrolled in 2013 is around 2,000. There is also an Oman Specialized Nursing Institute with the specialty of nephrology, midwifery, pediatric, and so on. And again, around 200. This is for employees, existing employees, nurses, who actually opt to specialize in different specialties of nursing. Around 200 a year enroll in these programs. Also, there are bridging programs and bachelor programs, both for nursing, for community health nursing, physiotherapy, and X-ray. Now, these bridging programs are done in affiliation with international universities, such as Cardiff University, for example. Now, this is where Oman compares with other GCC countries and some European high-income and upper-income countries. This is where we are. The plan is hopefully to get to 65 per 10,000 of the population for nurses and around 27 per 10,000 population for doctors. Still too much to ask for, but we have to aspire for these numbers. This graph actually shows projected required number for the next 50 years. And it actually shows that doctors, as time moves on, we need more doctors and more nurses. The human resource for health need increases. Some of the proposed strategies that are still proposed and under discussion is Health Council as a regulatory body, health policies, granting licensure, and also to stipulate the number of enrollments. Another strategy that is under process and being discussed this time is the medical city, and that's to provide specialty health services and also to act as teaching site for graduate and postgraduate levels. One of the areas that, one of the challenges that we face is teaching clinical placements for nurses, for doctors, for all health specialties. And so hopefully the medical city will act as one of the teaching sites in collaboration with Sultan Qابوس University and so on, and a health research center. Again, other strategies is to optimize the enrollments by either increasing student intake of students and scholarships. One of the things that is not mentioned here is I think we need to market for the health specialties from high school. We have to go and probably market and tell them why it's important and provide them with more information, because a lot of students, when they opt to go for other specialties than medicine and health related, they have limited knowledge of these specialties, and that's why marketing becomes an important one of the strategies that should be taken into consideration. Also looking at, so we're between two issues here. We have limited number of human resources for health, and also we want to focus on quality, and we have to be in par with international standards. And so we really have to create that balance. We don't produce only the numbers that we need, but also focus on the quality, so the healthcare does not suffer. We have to look at our teaching sites and hospitals. We have to look at accreditations, student bed ratio, student faculty ratio, and one of the proposed strategies is that entry into the health profession is at bachelor level. Frameworks and career pathways have been proposed also. This is just to show that it is really, it takes so long to have a specialist physician or a specialist doctor from a non-medical career pathways. So in order to plan, you really need to look at the 2050, 2100, and not just the short-term strategy, because it takes up to 14 and even more to have a specialized doctor. For nursing, the ideal track is bachelor and then experience, and then those who opt to go to be a faculty of nursing need to continue to do their master's and PhD, and those who go into the clinical